Okay, thank you very much and welcome again for the second case from Madras Medical Mission. With me, I have Dr. Vignesh, Dr.
Hi.
Ashish Chopra, Ganesh, sisters, and all of the technicians who are here to help me with this case. It's a very interesting case, so please go ahead, Ashish.
All right, thank you. So,
Yes.
coming to the case scenario, he's a 69-year-old gentleman presented with acute coronary syndrome, diagnosed as non-ST elevation MI, and prior history, he underwent a CABG with two grafts, Lima to LAD and SVG to distal RCA in 2004. So he has been doing well for the last couple of nearly about 2 decades, and now presented with non-ST elevation MI. And we proceeded with the CT coronary angiogram to rule out the patency of the graft. So coming to the LV dysfunction, he has a moderate LV. He is diabetic, HbA1c around 7.8, and hypertensive with an creatinine of zero point 0.9. So coming to the CT analysis, and this is the Lima graph which was patent and doing well yet. And coming to the venous graft of the PDA, where you can notice a tight narrowing at the juncture of the anastomotic site. So hence we decided to go ahead with the PCI to the venous graft at the anastomotic junction, and after which we are directly go ahead with the angiogram over here. So
Okay, so today morning's, thank you, Ashish. This is the angiogram. And for to hook the graft, so we don't do angiograms as diagnostics before the doing the case. So most of us do CTs first and then make a decision, and that's the current recommendation. Post CABG patients who come with angina need a CT scan first and then only a diagnostic angiogram because there it saves on a lot of dye injection, unnecessary hooking grafts. So here it's very clear. The circumflex goes good on the native. The Lima to LAD is normal. And the problem for his angina and his troponin rise seems to be that stenosis in the distal RCA vein graft stenosis. So let's play the angiogram in the morning. And you can see here, this is the vein graft to the RCA. We have a 7 French sheath in, we have a 7 French guiding in, and this is a multi-purpose guiding. And remember, all grafts should be hooked with a multi-purpose and not with other diagnostic or other guiding catheters because you lose support. So you can see in this view, which is basically an LAO 40 cranial 16 view, that you have a lesion which is ulcerated in the distal graft at the anastomosis of the PDA PLV junction. There's also disease in the proximal to the lesion, and the plan is to do IVUS guided imaging. We we can do OCT, but unfortunately there's no length here for the OCT catheter. So the problem is that we will not be able to get a good picture since OCT catheter doesn't have the length. Now the next question is, in a vein graft, the discussion would be, do we need to protect these grafts? Now, if you know that in 2005, due to a large randomized trial with one of the wires, the guard wire, we had data to suggest that all patients should be protected and during a vein graft intervention due to reduce of 30-day MACE outcomes. And this was basis of a class 1A guideline for this procedure of protection. But clearly we saw from the NCDR registry and from other registries that the usage of protection in the US and the Europe was only about 20%. And clearly the large registries started showing disparate results that putting a protection device in fact may create some harm than good. There are three reasons for this. One is because antiplatelet therapy has got better. Number two, we've got better stents, low profile stents, which don't cause much of distal embolization. And the third is that the whole technology of putting stents has changed completely under guidance of imaging and stuff like that. So in this patient, the question is, will you protect or not? The answer is no. We don't have place to put a protection catheter as filter wire. The filter wire would be useful for big grafts with large arthrothrombotic thrombi. Here it's a small distal vessels. We're not going to get any protection device through. And currently, both the European Society and ACC have downgraded the use of protection to 2A. So clearly, it's not a must to use protection. So my plan here is to wire the vessel into the distal RCA and then image after predilatation and see the length. Remember, in graphs, we always need to go good to good. Otherwise, you will end up with restenosis in some other area of the graft. This is a very old graft, but you can see that the proximal part looks very nice, but the distal part, there is some degeneration and lesion. So can I have the wire, please? So this is a, a multi-purpose guiding in the RCA, and I'm just going to get the wire down and then use a 2.5 balloon to balloon dilate
Would you
that.
like to use a 2.5 or 2.25, sir?
Yeah, maybe a 2 to 5, maybe okay. Small check, please. So I like to put it in the bigger vessel. Okay, so we're writing now distal.
So this is a 0114
Yeah, it's a cyan
routine
blue wire.
Sion
Yeah.
blue wire crossing distally. It's not a challenge. So we are taking a non-compliant 2.25 into 12 millimeter balloon. Pre-dilate, as we won't be able to cross the IVUS as it's a significant critical stenosis.
So, Vignesh and Ashish, what do you think? If this vessel was a bit bigger, would you protect it or not? Say this was a 3 millimeter distal RCA.
If it was a
Uh,
heavily thrombotic
Heavily
lesion,
thrombotic.
yes, protection may help as it might cause a distal this. But being
Okay,
at the
so before
anastomotic
we,
site,
yeah, so it's a very good comment that if you have a bigger vessel, this is a
This is a
thrombotic lesion.
thrombotic.
Now we need to do the first thing before you balloon dilate a graft is to put some
nitroglycerin.
nitroglycerin down, because it's very important to prevent microcirculatory spasm and flow that you give a good nitroglycerin. I sometimes please load up some nicorandil in case we have some no reflow. So I keep nicorandil on the table. So if in case I need some nicorandil, I will use it. So sister,
Yes,
please load up some nicorandil.
Nicorandil.
So sister has preempted that. She has loaded up the nicorandil. And this is a 2 to 5 balloon, as we said before. That's the balloon coming down, no difficulties at all.
All right.
Yeah.
Okay,
Can you
so
go up,
let's
sir?
go up there
Yeah.
slowly. So all the time we are watching the ECG to see
Going
for any no reflow.
going to nominal 12.
So it seems to have reasonably come up. Small check, please. Okay, we do it here.
So the flow is good.
So it's
There's
good.
not much of.
12 nominal.
Deflate.
So we have again
Small
pre-dilated the
check.
proximal junction. And we have taken a cine over here.
Okay, so as you can see clearly, the vessel is now looking a bit bigger.
Bigger.
And what we're now going to do is give some nicorandil into the coronaries and then use the intravascular imaging to see where we are. So remember, with EPI filters, there is about 2 to 5% chance of either the filter creating embolization, the filter getting into entrapment, and sometimes the filters are too big for the vessel size, like this patient, and too distal. You can't put the filter if it's too distal. So all these make protection a bit difficult. And remember, the data in 2005 was with the guard wire, which made the Sapphire trial makers use the protection device. But today, nobody uses the guard wire. So really, I think that we have now a little different data. And I think based on this data, I think there was also a large, I remember, meta-analysis in circulation cardiovascular intervention saying the same thing, that in fact the use of protection may increase bad outcomes than really help. So okay, so we are ready with the IVUS, and let's go ahead with the IVUS. Yeah. So this is a Boston high definition IVIS, which you're going to use to check the graft. So that's the IVIS coming down, no difficulty at all. We'll go right
You have
distal.
crossed, sir. Yeah.
Okay, and now we'll take some pictures. Okay, so we have put the machine on. Get the IVIS pictures, please.
Yes.
Imaging,
Ready.
sir.
We've gone down,
So
and
it's
this
a
is the
live view.
distal RCA.
It's into the native vessel
Yes.
and it's pulled back.
Recording, sir. Yeah.
All no luminal normal appears to be nominal and coming at the
So we're close to
vein
the
grafts.
lesion now.
This is one of the
That's the
branches of the
branch, the
Branch.
PDA. And this is the lesion. You can
this was a
see,
tight stenosis lesion at the vein graft junction. It's more of a fibrotic, not much of calcium. Again appears to be reasonably good sized upper vessel at the vein graft.
so you
Oh,
can
yeah.
see that the graft sort of here becomes almost normal. There's mild intimal thickening of the graft, but otherwise you can see the graft is reasonably good lumen, and looks pretty good. It looks like a big graft with about definitely the proximal and the
More
mid
than around
grafts
3,
looks
3
almost
millimeter.
3.5 to 4 as we come back. So this is all looks okay. So what we need to now do, Ashish, is to
We'll
please tell
stop
me.
over here.
Yeah, we can stop here, and please tell me what is the distal diameter, what is the proximal diameter of the graft, where it is normal vessel, and what size of stent do we need to use.
Multiple branches over here coming to these tight stenosis.
Yeah, somewhere there
I
maybe.
may go ahead with here.
This is an anastomotic point.
Just a little bit. About 3.
3.75, so
Take a
it's
sir. 3.5.
about 3.5.
Okay, can we just go to show me that branch, the small PDA?
Oh,
Yeah, so
yes.
that's the PDA. That's the native right. I would rather put the stent into that native RCA. This looks like 2-ish, maybe a little bit more than that.
This is 2.5. It's 2.5.
Yeah, so it's a bit more than 2.5. Okay, so that's where I would like to
So
put the stent, start the stent, because as you come there, yes, it's a graft, there's disease in the graft, and I don't want to be just at that junction.
this is the lesion portion.
Yep.
You can notice the vein graft was about 3.5 and at the lesion it is about 2.5. Coming to the proximal,
Yep.
uh,
There's all disease there.
yeah, the nominal is here. It's all diseased.
So the issue is that we need to cover good to good, otherwise we'll land in trouble.
So let me assess here, then take a decision what has to be done.
3.5 at least.
Yes. So we need a stent where we'll be able to cross,
Get a 2.5 distally and get to
get to
3.5
3.5
proximally.
proximally.
And what is the length, please?
34.
Okay, so approximately a 34 millimeter stent, maybe a bit more or less. Or
I think
is
we
it
have
34?
34, 33 is also good. So these all are diffusely diseased grafts, so it's better to
Okay, so I need a
address.
stent which will go from 2.5 to 3.5, which is about at least 34, maybe 36.
34 should do because we
34
have
should be
one.
okay?
Yes,
Okay.
because we have one or two here. Also, we have some space.
So what stent do we have, Ganesh? What about get me a
Metronic, sir.
34? I don't want to get shot. Get me
Yeah.
a 34.
Oh,
Metronic.
Onyx will go no 3.5. Onyx will go to 3 here.
Onyx will go to 3.25. 3.25.
Okay. And you have a resolute
Or
integrity.
0, sir.
So the issue here is that we need a stent which has two diameters, 2.5 and 3.5.
We can take Onyx, sir. We can take Onyx.
Or 0 boom, sir. Or 0 35 will
Okay,
go.
anyway, if we don't have the resolute
We'll use
integrity,
the or 0, sir. 2.5 35, which will go up to
2.535 goes up to that size.
Onyx will go up to
Onyx. Or 0 will go.
Resolute Onyx.
Check and open.
R0 no.
Okay, let's get the Onyx. Get me the 2.5 Onyx to 3.5. Okay.
Onyx.
Get the 34 Onyx, please. We can always go up a bit.
R0 will not go, sir.
So obviously it's a old graft which is about 20 years, and we expected some amount of degeneration where you can notice a
So if you
fibrotic
look at this
flaw.
angiogram, you can see that we need to deploy this graft somewhere at the second marker level. That's where the lesion ends. You can see that? So you need to go distal into the RCA and then come back into somewhere around that between the first and the second marker. So freeze this picture, please. So we're using a Onyx 2.5, which technically goes up to 3.25, but I'm sure we can push it up a bit, quarter millimeter more. Let's see how it goes. So this is a 34 Onyx. That goes in very easily. Small check. So we don't need to go that distal. Let's take a shot.
Yes, sir.
Okay, so approximately we're okay. Distally
Distally
we're
also we are okay,
just
sir.
short,
Probably one
maybe a
it's
little
moving
millimeter
bit,
in.
so
Pull the wire back so the stent doesn't move. And keep it there. Okay, let's
slightly
take one more
moving.
shot, please.
Yes, sir.
I think we are good to
Okay.
go, sir.
Yes, sir.
Approximately we are fine.
Okay, let's go up, please. Yeah. So
And
what's
distally
nominal
also
at?
is fine.
Going to
We
12,
can
sir.
go nominal pressure of 12.
So we go up to 12 and then keep the 2.5 balloon high pressure ready, please, sister. Keep a 2.5 high pressure balloon ready.
Go up again, sir.
We can again pre-dilate once more. The
We're
same
going up to the stent again. 2, 4, 5, 6,
small
7,
stenis.
8, 9, 10, 11.
Yes, sir.
Just do that once more. So there's some ECG changes during the dilatation of the stent. We should keep the nicotindle ready in case there's any no reflow.
I think
We get
distally we
this
are well
down.
expanded, so as it's a vein graft,
So we'll give some nicotindle again, please. So let's give some nicotindle again to see that the reperfusion is good in the distal vessel. These grafts are notorious for no reflow, and you need to take every step to see that the flows are well established each time you put a balloon or a stent. Okay, that looks good. So let's get a 2.5 balloon high pressure, please. 2.5 balloon. And keep a 3.5 balloon proximally, please. So the flows are good. We're given some nicorandel to maintain microperforation. And we're going up for the distal part of the stent with the 2.5 balloon and the mid and the proximal with the 3.5. The part of the graft we'll do at 3.5 and the part of the native vessel at 2.5. So there goes the balloon. And we're going to do a stent boost now, please. Get the filters in.
So call him at the
Call him it.
yeah.
Okay.
So we ready with the stent
Stent boost ready, Ma?
long cine. Okay, we have crossed beyond the stent, I think.
Okay, we're beyond the stent. So we come back a bit. Okay.
All right.
Go up there.
Going to 12 nominal.
8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
Yes, sir.
Open the filters, please.
Yes, sir.
Reflate, please. Go up. 23.5 balloon ready, please. Go up, please.
Yes, sir.
20.
20.
Okay, so we've done enough there. So what we'll now do is with the 3.5
3.5
balloon, the graft area, and then have a look and then do an IVS and see what's happening. Okay. So the results of vein graft interventions are pretty much not very great. You have a 35% restenosis rates in vein graft interventions. The most important thing is to cover from good to good as much as possible. This patient had a totally occluded right. If you see the CT, there's no way we could go through the native CT, a native right. So it's more easier to go through the graft here because the graft was very short, discrete lesion.
So, but prior interventions were not image guided, so I'm not pretty sure now in future how is going to be the.
Yeah. So I think today, saying that the graft interventions are not as good may not be completely correct. Most of this data is very old data. If you really look at current data of current new stents, image guidance, good antiplatelet therapy, and obviously aggressive lipid lowering, you may get better results. But we don't have contemporary data with vein grafts to tell us that. Okay, so that's a 3.5 balloon, and I'm just going to do another. Get the filters in, please. Okay, small check. So we need to be within the graft all the time here for the 3.5.
We'll dilate here and the proximal will use a stent boost.
Okay, go up here, please. 8, 9, 10, 11, 12, 13, 14, 15,
18, sir.
16.
All right. It's a good expanded post dilatation with the 3.5.
I'm
So
going
at
to
the
do
proximal
another.
edge, we shall just use a stent boost to visualize
Let's do the
exact
boost.
proximal optimization.
So we use both stent boosts and IVUS to make decisions of how your stents have expanded. I think there's some utility, especially with fractured stents of stent boost.
All
We
right.
also see very clearly now. You can see how nicely we can see. I'm just pushing it a bit in as you go up. Go up, please. 20.
So it's a good expanded.
So this is a
Proximal.
3.5 at 20, well
Obviously, the stent
expanded.
boost showed some under expansion, but looking
Bones
at
and
it,
go
I
apart,
think
sir.
it's a good
Go back,
expanded
small
stent
check,
right
please.
now.
We go up here again. 20. Keep the IVs ready, sister, please.
Okay, sir. Clear.
Deflate, please. Go up again. 20. Okay. I think we've done good with the balloon. Open the collimation, please.
So we shall image and we'll take a cine over here, see the distal flow, and let us do imaging and see how the optimization has happened.
Okay, let's take some nitroglycerin on icrandyl first and then take the IVs in.
Test. Sini, sir.
All right.
Okay.
Yes, sir.
Okay, it looks all right, but let me just do an IVIS and be sure we've done it. Okay. Okay, let's get the IVIS down, please.
Hmm?
Okay, so we go distal to the cat this time.
The lives on a
And that's it. Okay. Let's go ahead. Image, please. So that's a
So
distal RCA.
this is a distal RCA. We're coming with a pullback, and notice it's small disease, and coming to the distal segment of the stent. So this is all into the RCA branches. So the distal segment
Stent.
appears to be good, as well as there's no dissection or any flow abnormality. And this is one of the side branches, which was noticed, the PDA branches. And this is the vein graft, which is a reasonably well expanded. And if you can notice, the expansion, overall expansion appears to be good. Coming to the proximal portion where we had a size of about 3.5, whether these stents can stretch up to, and I think it has expanded. It has expanded over here. I don't see any under expansion at this portion. I think
Okay,
we are
now we're in
good.
the normal segment.
Normal
Can we just
segment.
see that distal part of the vein graft attachment to the native RCA? Is that okay done?
Yes.
So I think this should be the anastomotic site.
Okay. Can we make some measurements there?
Which is about 6.9, and coming to the distal segment,
It's normal RCA. That's where the stent is.
Yeah.
which is about 4.9. I think it's reasonably
Yeah.
expanded more than 100%,
I
and
think
I
when
don't
you
think so
also
there's
see
anything.
some prolapse already of the plaque
Yes, I
inside.
don't think so we can be able to expand even more further.
It is
So
like
this distal size
homogeneous
itself is
prolapse, sir.
around
I don't
this
think.
much, and the proximal segment at the anastomotic site is 6.9. So we have expanded more than 100% at this portion. And coming to the proximal, so obviously it was a 3.5 at the proximal portion of the vein graft, which is about 10.
Good expansion.
Okay, so
I think
I think overall we've got a reasonably
Expansion.
expanded stent. The distal diameter seems a bit low, about 5, but I think the vessel is small. It's only 2 to 5 vessel. And I think that, we should be happy with this.
So it's nice.
What do you think, Ashish? And
Very
I
nice.
think so. So distal
Nice,
vessel
sir.
itself is about the same. It's and our stent expansion is also about 100% at this beyond the stent, I'm saying.
And
So
Smotics.
I don't think so there's any chance.
On
Small
Smotic side
tip
also
collapse.
there's a good expansion.
Expansion
Nice,
well
sir.
is good. Proximal is also expanded well with the 3.5 balloons. So we are normal to normal segment is expanded stents.
okay,
I think he should do well.
so let's just give some nitro, take the last shot. So the aim of this procedure was to show how CT can make most of the diagnosis. We don't need diagnostic angiograms for grafts anymore, unless you're unsure of something. The second thing is that you don't need protection for all grafts. So especially when the grafts are small and they're not having distal area to keep the protection devices. And the third is that when you do a graft, you need to go from good to good. And sometimes in the crossover from the native coronary arteries to the graft, there may be a size mismatch, and you need to use imaging to guide your procedure so that you have the best outcomes. And here you saw it was 2.5 native vessels, 3.5 graft, or stent graft, a stent which is 2.5 distal and 3.5 is important. Post dilatations are important, and IVUS and imaging is extremely important to go from good to good. So with that, we'll take the last shot after the wire. And we hope you all enjoyed the case. And take another perpendicular view. Yeah.
PA green.
All right.
It
Very
looks
nice.
very good, and the result looks extremely pleasing. So I think we'll end with this, and I'd like to thank again Dr. Vignesh, Dr. Ashish, all the cath lab staff and the technicians for helping us to do this case. And we'll see you next week, Wednesday, for the next 2 cases. Thank you very much.
Thank you.
Thank you.